I welcome you to Masholanand Central Province, together with my colleagues, the Fungai and the Sengwe. They are local guys. We work together every day. But I've met some of you before. Victoria, I think you don't know me, but we've interfaced a lot. The others came to Mashingo, and all of you have read your articles or heard your voices on radio and television at some point. Masholanand Central Province, I will start with the population is at 2012. Of course, more people are getting born, but officially we have 1,139,940 people according to 2012 statistics census. Then in terms of prevalence rate, we are at 10.2% as a province. Then in terms of incidence, that is the number of new infections, according to 2019 estimates, we are at 0.25%. Then in terms of number of people living with HIV in the province, those who are living with the virus, we have an estimated number of 78,709, of which that figure is disaggregated into 5,178 children and 73,530 adults. But the number varies almost every day. But this is as of the first quarter, the period ending March 31. Then we move on to our situational analysis in terms of ART coverage. All our health facilities in the province, we have 100% ART coverage. Then in terms of HIV knowledge, according to the Zimbabwe Demographic Health Survey of 2015, the knowledge of HIV in the province is high at 81.7% of the population. And this one is for men, and for women is 90.1%. For the age group 15 to 49 years. Then in terms of knowledge among the youth, it is a little bit low. It is, according to Zimbabwe Demographic Health Survey of 2015, we are at 38.8% for boys and 41.9% for girls. Then we also have issues or problems in the province that we are trying to respond to. You would find that most of the HIV burden now in the province is affecting youth, adolescents, girls and young women. Those are the sub-population group that is most hard hit. And we also have a group known as key populations. In this context, for our key populations in March Central, we are focusing more on those who sell sex, either men or women. And our focus also targets mostly young girls selling sex, because we also have a problem that is currently emerging in most urban setups, especially areas like Glendale and also Bindura, as well as Mount Darwin districts. That problem is now prevalent of young girls selling sex, and most of their clients are artisanal miners. This province is endowed with a lot of mineral resources as well as agricultural activities. So that wealth is also, being a blessing, has also brought some problems associated with sexual activity, as people try to get the elusive US dollar through, selling sex. So that is one problem, which is also contributed to a spike in STI cases. We've done a lot of interventions trying to reduce this issue of STIs, but the fight is a tough one, because the figures or the statistics we are collecting continue to show some increase, despite all the efforts being done in the province. Then in terms of youth, adolescents, girls and young women, we have a problem of sexual violence in the province. I'm sure most of us here could have read in the newspapers, radio, that during the COVID period, we recorded 5,000 plus. That is according to newspaper records. And it is also congruent in terms of the estimates of 2019, and also according to the multi-indicator cluster survey done in 2019, which shows that we have that problem. Districts mostly hit by the GBV problem, focusing on sexual violence, including Mbire district, is recorded quite a big chunk, or they have a bigger share of the problem. We also have Rushinga district. We also have Muzaraban district. Then we have Bindura district as well as Shamba district. So you'd find that the epidemic in this province is driven by a number of key factors. Among them include multiple concurrent partnerships, where a man or a woman would have the luxury to have sexual intimacy with one or more partners. That is prevalent in the district, and especially Kumakroboza Batutaura, and also among farm workers, where wife swapping is the norm, and the wife exchange. It doesn't matter, today I'm married to Joyce, tomorrow she's married to Peter, and Peter can recall a former wife as well. So those are some of the practices that would then drive the epidemic. Then we also have another key driver, incorrect and inconsistent use of condoms. We've tried our best, working together with all partners, but you'd find that behavior change cannot happen overnight. So it depends with the person, but people have got information, as I alluded to earlier, that our knowledge levels of HIV is high. But our challenge is at the personal level, where a person will then have to decide. Some can have it today, tomorrow they don't have. So the inconsistencies come. Then unequal gender relations is another key driver, which then lead to gender-based violence, where men, due to our patriarchal society, continue to enjoy power over women. Therefore, in terms of sexual negotiations, other negotiations, women are on the receiving end. Then we also have low risk perception. Some saying HIV is for others. There are some people who just believe that HIV is meant for other people. So that problem is still there. We can't point to a particular group to say it is prevalent among these ones, because we haven't done a survey. But just from SNP surveys, you do find that some people believe that maybe those who sell sex are the only ones who will get STIs, which is not the fact, because anyone can get it. So low risk perception is one of the key drivers of HIV in the province. Intergenerational sex, where someone 10 or more years older than someone gets married, an old man like me marrying a 20-year-old, and that difference, because of the sexual experience, are also related to unequal gender relations. You find that power dynamics now come into play, and these are some of the reasons we have established as problematic. Key affected areas in terms of geolocations, I have said mining areas, and these mining areas include Jumbo mine. Of course, nowadays the problem is a little bit low because of interventions that were put in place to decongest the mining activities that were there. But we have another hive of activity in Mukaradzi area in Mount Darwin, where people then flock to in search of the gold and other livelihoods. So those who sell sex will always follow as well, because where there are artisanal miners, there is also ready cash. Not only artisanal miners, others are also in the trade, other goods and other services. So there is ready money for sexual activities. So besides these mining areas, we also have farm compounds, we also have business centers as the hotspots in our district. I think I have already mentioned them, adolescents, girls and young women. We also have another group which is affected, a special group, youth in tertiary institutions. We have 2 universities in the province, ZEGU, Zimbabwe Good University, and Bindra University of Education, Buse. So we continue, we also read and we interface with the authorities to establish problems that may be affecting the students. And we have noted that cases of STIs are also reported to be increasing. Also gender-based violence, where maybe boys or men are fighting over the youth, the girl youth or the student. So some have even gone to the extent of being murdered or gone into other problems besides HIV. I'm just trying to say, in terms of these sexual relations, they can also lead to other effects. And this is the problem that affects youth in tertiary institutions. We have also had the stories. We need to determine, to say youth in schools as well. There are problems. The problem which affects youth in schools is early pregnancy. We also have early child marriages. We also have high school dropouts due to a number of factors. The factors include the pregnancy, but they also include migration to look for opportunities. Because you talk to the young boys, they leave school. It's not only the young girls who are leaving school, but also the young boys are also leaving school, especially in those areas where mining activities are the major source of income. People see John wearing a new jean trousers or having a new pair of trousers. So they'll say, should I wait for 16 years to get a degree? Or if I can count 1, 2, 3 money, then I should go for money. So the problem is affecting both girls and the young girls. But of course, when we focus on HIV, we find that the problem of HIV STIs is more prevalent among the young girls. So that is the problem we have here. So in terms of our prevalence, we have the Mazowe district having the highest prevalence rate at 11.9%, and the Rushinga district at 6.1 being the lowest. Then we move on to ART coverage. In terms of how many people living with HIV are covered in terms of getting the medicines, you find that overall, on average, the province is 97% in terms of access to ART services. These are the latest figures we got from the 2019 estimates. And the Bindura district enjoys 100% coverage, with Shamba trailing, or is the least in terms of coverage at 74%. But generally we are happy. Then in terms of HIV burden, our province is rated as moderate. It is not in the red zone because of the interventions that have been done by many partners. Then we move on to the health services. We have about 147 health service points offering various services, including PMTCT and the ART throughout the province. Then as the national coordinator of HIV, now I want to talk about our coordination mechanisms. The National AIDS Council is the mandate to coordinate the multi-sectoral response to HIV. I'm sure we all know that. So by that we work with partners, we work with stakeholders, and we also work with volunteers in communities. So we have a number of partners, some of whom include Africa Aid. They focus on what is known as the CATS program. They've got a program known as Zwandiri. This program focuses on assisting adolescents living with HIV so that they adhere to their medicines, they adhere to other advice given by health workers. We also have SESHA. This is an organization we work with that focuses on assisting those ladies who sell sex in terms of preventing HIV. HIV, yes, they offer HTS, they also offer STI treatment services and also counseling. So they operate in Bindura, they operate in Mazowe district. We also have other groups, organizations. We include Zahachi, who are into GBV. We have Population Services International. We have FHI 360. We have SAF-AIDS. We have ZAPSO, Zimbabwean National Family Planning Council, World Vision, Musasa Project, ChemFed, ITEC. Those are some of the key implementers we have in the province. But we also have a number of other community-based organizations, including a men's forum in the Chitsungo area of Mbire, which also operate in Muzarabani. This group aims to engage men so that at least men try to would dialogue and introspect, especially in those GBV hotspots areas of Mbire, so that men begin to discuss the problem and say, how do we find the solution? So this is a local grouping. We have a number of other CBOs being formed. Besides these CBOs and other major stakeholders, we also have faith-based organizations, church groups who we work with. Then the most key stakeholder we work with is people living with HIV. That is through ZNNP+. And another organization called Geographic. These are groups of people living with HIV, and they are there to represent the interests of their membership. Then, of course, last but not least, we work closely with the media as well, because we believe that the media is the conduit through which the greater populace would then be able to understand what is happening. It's the window through which people would then be able to know what is happening. So we are grateful to the media because they played a very significant role in terms of knowledge, imparting knowledge to our communities, in terms of influencing behavior change, and many other factors. So that is all in terms of our stakeholders. Then in terms of response, I alluded to earlier. What are we doing? As NAC, our major role is to coordinate. So these many other stakeholders or implementing partners I mentioned are the front runners. They are the foot soldiers on the ground doing different interventions. Some are into treatment, others into prevention, but ultimately we converge because the National AIDS Council, using what we call the 3-1 principle, we then have to ensure that all implementers, anyone who is doing HIV in the province, is to report through the National Monitoring and Evaluation Framework, which is housed by NAC. And also NAC is to know who is doing what and where. So that is our role. So basically, but we also have an additional role where sometimes we fund. So I'm going to talk about models, HIV prevention models we are implementing and that are financed through the National AIDS Trust Fund. The first one is the SASA model. SASA model. SASA refers to, the first one is, it refers to, it's a model that is focusing on alleviating GBV problem. So this SASA model was adopted from Uganda, where it was used by a local NGO there, and was seen research done or evaluations done. Findings proved that this model is useful for engaging communities, especially targeting traditional leaders, traditional healers, faith-based organization leaders, influential leaders within communities and the general populace in terms of discussing the relevance of certain values, norms, attitudes, and ideas that were inherent before and now. And we are saying, do they work for the negative or do they work for the positive? Some of the values, ideas, attitudes that point to HIV infection, that point to violence against women and children, that point to unequal power relations, are then put on the table and say, what should we do? So we have seen that such dialogues have assisted greatly, evidence on the ground, which we gather through the program monitoring we do every month, as well as the periodic evaluations we do. We now have evidence that shows that these interventions are working. For example, Bindra district was once in the top 3 in terms of GBV. But you remember that I did not include it last year, the top 3. Why? Because the interventions here have already proven that they have worked. We now have testimonies. If you go there, they will tell you that though some of them Nicodemously. The women and the children, we meet them. The nurses, we meet them. They tell us, mining are now coming to, for ANC service, for example. Mining are now coming for treatment service, for example, because of the interventions that were done. We are also very grateful to other actions taken by very influential people, especially in Shava district. Last year, the First Lady of Zimbabwe, actually came to Shava and did some interventions with the chief swaps. And that intervention was well documented, and that intervention is proven. Kushamva was one of the epicenter the GBV. But if you go there today, you would find that most of the white garment church members have accepted conventional health services. They are no longer believing in but now people, pregnant women are now visiting the health centers for such services. So SASA is a model that is aimed at reshaping societal values, norms, attitudes, and behaviors with the objective of reducing GBV, which leads to STIs and HIV infection. Then the second model we are implementing or financing as NAC is the DREAMS program. The DREAMS program focuses on vulnerable girls, those who are disadvantaged or those who are marginalized and have less opportunities to grow in terms of schooling, to grow in terms of livelihoods and other health-related situations. So we find that DREAMS was pioneered in the country through PEPFAR. Districts, our 10 hotspot districts in the country, and in this province we have got Masowe district. Implement a program, DREAMS. Program Yoyo is being implemented through a consortium of implementers, and they use an approach which they call layering. So we have Zimbabwe Health Interventions, ZHI, looking at these cultural norms, these traditional norms, trying to engage communities. It follows almost the same methodology like the SASA, trying to question the people's beliefs and in terms of attitudes, in terms of how they view women, how they view children, with the objective of trying to change those norms for positive so that we alleviate HIV and STI infections. Then we also have SESHA, which is focusing on sex work. That is in Masowe district. I'm talking about the layering. ZHI, cultural issues, and values. SESHA, looking at sex workers. We also have our hospital. It's part of they actually focus on school subsidies, so that those girls who would have dropped from school and are willing to go back to school, they are then assisted with the stationery, school uniforms, and school fees. So that is part of the interventions as well. We also have other organizations within that consortium who also focus on people with disabilities. We also have others focusing on ISALs, trying to empower the girl child so that they have the skills to then look for better livelihoods other than sex work, or livelihoods that would put them into dangers. So dreams simply means determined, resilient, empowered, AIDS-free, mentored, and safe. That is what dreams mean. I hope you all got it. So at the end of the day, the interventions are meant for the girl child to realize her dreams, in short. So that is what it means. So after realizing the fruits or the gains from this intervention, which is now more than 5 years old in Mazowe district, along other 10 districts throughout the country, NAC came with a modified vision, which we are sponsoring as well, which we are funding. So we are now funding a modified vision of the dreams in Muzaraban district. We also have modified dreams in Rushinga district. I'm sure you're going to visit that district. We also have modified dreams in Mbire district. So we are focusing mostly on assisting disadvantaged girls with the school subsidies, paying school fees, paying, provision of stationery, uniforms, and other needs, sanitary wear. But above that, we also train teachers in comprehensive sexuality education, because the Ministry of Education, through its teachers, they are the only ones who can impart knowledge to school children. So we need to capacitate the teachers so that they impart knowledge to their kids. And so that is what we are doing. We also have what we call a component within that dreams, what we call parent-to-child communication. We can't target the child only, leaving the parent isolated. We are now engaging parents so that parents will be able to have those social skills to engage their own children on sexuality, SRH issues. Because I am good at talking about SRH issues to others, but what am I doing to my own kids? That is the question. Even as a health worker, people are beginning to ask each other to go, because most people are but I am not able even to talk to my own daughter, because it's taboo. But when it comes to community, people, open. So we are trying to, undo that, and trying to give confidence and trying to say this is possible. A father can talk to her daughter on sexuality issues. A mother can talk to her son on sexuality issues. Because if they keep quiet, they will keep quiet until they see a problem blooming in the form of STI or HIV. That is the danger of keeping silent. So we need to engage. So this is one of the objectives why we are focusing on that, so that children, teachers, and their parents come together so that they actually discuss one issue. Then the third model is the key populations model, which we are implementing or funding in Mazowe district, in Bindura district here, and also Muzaraba, Mount Darwin districts. Ndoka tukita program yowasikana kana madzimai vanotengesa bonde nekuti kune problem yechi yemakorokoza yandataura iyayi vanenge vachiteera mari iyayi. Kunewo zvakare vanotengesa misika yavo nekuti makorokoza vanoda kudya, saka kune vanotengesa zvipfeko. So kune hive of activity in terms of economic activities which brings ready money. So we are also funding interventions there so that we try to reduce the impact and also reduce cases of new cases of STIs and new HIV cases as well. Then the other model we are funding is the CATS model. You know, the CATS, Community Adolescent Treatment Supporters. Community Adolescent Treatment Supporters. Ndiana botaura kuti yakatanga nezvandiri Africa Aid. Ndio wakatanga kuya program iyoyo vachiti vana vadiki vabatsirane pachavo kupanana counseling, kukurudzirana kuita adherence so that they continue to live and also lead healthy lives. So these kids are trained. Pane course yavanotoita about a 5-day course, then they graduate, they are actually given certificates, and they are carefully selected so that they are able to give others information and to assist. So they work through health facilities. So they are trained together with the health personnel, and they will be reporting to Ministry of Health, my clinics. As what support was only Zwandiri. But then Zwandiri is not covering all the districts. So as NAC, we came in to cover the gaps. So we have got three districts we are supporting through the National AIDS Trust Fund, which include Rushinga, also Shamba, and Bindura. But of course, Rushinga Tichengeta Mira, because recently Zwandiri yakati yane mari zvakare yekukavha Rushinga, which means NAC inosara ichingokavha those two districts dzine magap. So as NAC we identify where there are gaps, then we come to cover. Where implementers are already giving service, we don't go there because we then need to have 100% coverage so that we also do not do double dipping. So in terms of our responses in this province, takanangana prevention, which is the major focus in National AIDS Council to prevent. Those are the 4 models we are funding. Then on top of that, I have said we have a number of implementers with diverse or different interventions as well throughout the district. We are not satisfied with the coverage at the moment, so we will continue to appeal or to, kindly ask those with the monies to come to the province so that they cover the gaps, especially in areas of to do with the GBV. We still need a lot of resources so that we actually establish the reasons. We are going to carry out some studies together with the Ministry of Health and the Ministry of Women Affairs. We have already had some discussion around that area so that we carry out a study to determine why the province continue to be on the top 3 or so. Yet we also have many players doing a lot in terms of investing areas AGBV, EY. It's like we are investing, but the problem is like also growing. So we really need to establish which strategies we can apply or employ so that we try to reduce the problem, because GBV continue to be one of the problems that actually fuel an increase in STIs and HIV cases. Then as the National AIDS Council, we are also contributing to the response to COVID-19. As a province, last year we managed to assist our health ministry with the PPE with 10 million RTGs, our local currency. We contributed. It's not only my central, that was done from the national, but each province was allocated 10 million RTGs. So as a province, we benefited PPE yakapiwa kune vashandi vekuzvipatara say contribution. We also sit committees anoita COVID at provincial level and also kuma district level. And our task is to raise awareness. So we're a member of the publicity and information giving committee that raises awareness within communities. NAC is a comparative advantage in terms of this area because we have decentralized structures. We work through community volunteers. So our volunteers, when they are trained, we integrate COVID issues, we integrate TB issues. Anything that is related to the HIV epidemic, we also integrate. We can't isolate. So that is how we are responding to COVID-19 and HIV in the province. And we are working with other sectors through the multi-sectoral approach. Otherwise, ladies and gentlemen, this is my brief. I can entertain questions if there are clarifications. Thank you. We would start with the issue of retaining them within schools. You know, I mean, the other problem is so the only way we can give information to youth is through the classroom. And the only person who can give them information is the teacher. So one of the interventions we are doing to make sure that information reaches the youth is to capacitate the teacher through the comprehensive sexuality education. And that's our AMT took our trainer through the DREAMS program and working together with my partners like I said, Zimbabwean National Family Planning Council and even the Ministry of Education and they actually come with stakeholders. But the problem is they are now dropping from school. So when they drop from school, already they are cut off from the information. So this is one area where we are saying, let's retain the kids in schools. Once we retain them, then they will have the information. Because when the evaluators come, or those who do my research, they'll be interviewing those guys in my book. I think they're going to grade 2, grade 3. But wakama ngane HIV andakamo zizwa radio. Wakayaso ngwa deep here. Chama chimbondisia akutofunga zvengomo. So that is one area which we need to strengthen school-based HIV programs. I think they work for primary and secondary school kids. Then for youth in tertiary institutions, we are working with partners like Say What, that youth-based organization that is based within universities. I'm sure you are going to meet them when you come back for the Bindura tomorrow, because we have also engaged them. I think they are willing to talk about these issues with my universities. So my universities, we are doing our best. We do my orientation, we with my badges at Novaitira Wachuya. We work through my dean of students. They come here, they ask us to organize service providers, those who can give information. So they have maybe 1 week where new students are given this information on STIs, HIV. Besides that, they also have some days where they actually gather for sports events or such, but they also invite us, my universities, so that people can go there and continuously give information. They even ask us to contribute to my website, our name articles, HIV, so that their students continuously read. So the efforts are there, but of course, we can't really be there. I think I also left out the programming area. At Chaite general programming, at Chaite programming, because we now know from the evidence that most people are aware, but the problem is behavior change. But we are now targeting the marginalized, those who are left behind by the mass information giving exercise we were doing before. So this is now time for targeted programming. As we move to 2030, we need to move to look for those who are left behind. So these are some of the sectors, the youth. So all the resources, all the investments, most of the investments are now targeted towards them. So I'm sure with this vigorous campaign, I'm sure we are going to win the war and raise the awareness and also their levels of information. Yeah, it's both quantitative and qualitative. Changing the mindset is a bit qualitative. So, which means we need to do we had scored successes. I want to be honest. We had done, but this COVID thing, then it reversed most of the things. Was the reports we read during the last 2 months or so indicate a reversal of the gains. We had moved up, we had gone, but we now want to establish the extent of the damage. Right now, the Minister of Education and the Minister of Women Affairs, they are busy. Nema figures, nema registers. Of course, takabuda mapepa kuti vana vakawanda vakadaidai, but takazokumbira kuti vachinyasoita maregister chaiwo kuti vana vakwari muklasi A vasina kuuya chaende papi. So we are most likely going to get a good picture soon, but the problem is there. And it was exacerbated or worsened by COVID-19, which reversed the achievements we had obtained. But now that we are now integrating the response to COVID within HIV programming, we hope to catch up and continue to lead. Then we are going to win the war. Yes, and these models which I mentioned, I'm sure the evidence on the ground, the interest from the community leaders and even the youth themselves point that if we continue to do it vigorously, we are going to do something. But of course, we would need to determine our success through my evaluations, which are scientific. Yes.
In terms of the article program
coverage, yeah, like she mentioned, like she mentioned, Shamfa is in a posture one. That's one thing. It's religious factor. So when I'm going to touch one. But because on access, because on medication, medicines, it becomes a challenge.
So which type of apostle?
The original one, the ones like with the biology.
Like mine.
Yeah. You want to one day, but at the end of the day, when I get my work, so you know, evidence pane mumakato. Panning and going on the Bamsuno, and the
16. We 150.
No more food. I can't rob Mukazo, 16 with a boyfriend. Somebody before cases as late was my beliefs. But at the end of the day, you know what happens in a polygamous family. Some of them would then look for my Bentain and what was the men would not be able to cater or in whatever service they need. But somehow they end up going somewhere. So we believe in such a relationship, pane opportunity with HIV in East here. That is why now attitude you could have when you know chipatara. Kuonekwa mkaziwe mposture kina chipatara iturinya anga utotongo. So we are trying to engage them through SASA. We are making headway in Sham, especially the young women. They are actually understanding it. Recently, Takambita workshop, you were there. That lady here, you were there, she covered the story. She actually stood up, I didn't know about my story. She covered it. I will know, I'm now empowered. The and I'm going to go with my colleagues. So that way, that snowballing effect will then cascade into bigger numbers later. We start slowly, but we will crystallize into something great very soon because we need to hit hard and engage, especially this by my chiefs, in my traditional leaders, in my community leaders. What we want to work on is to target you what you tell woman, because the one kana mfuna kutaura iwavo kana vasati vataura ivo hapana anoekta because I don't know one authority yakadi kuvanhu but one influence.
Saka matimambosvika here kwacho ukoko ndokunonzi kwanoa uko kushavha kwavakazvarembe kwamaraka imi matimambonyatsosvika ndopanogara vakuru vacho pachidzidzo pacho ipapo
chidzidzo takambosvikako but efforts to engage them ndo zatiri kumbotrack tinyasogara pasi because vandakakubvunza kuti munotaura nezvei they know already kuti munotaura nezvei vanozviziva they know your objectives but to make them sit down is what we now need to do. They will try to be elusive because avaiti sekuti vari kuramba but vanongotsvaga way yekuti hamusangani tichasangana yende masangana parodi no ndifonere next week paunofonera anondiblawa haadi handisi kudai anda kuti no we will meet 1 year gone. That's the problem now. In terms of sex work, sometimes it's how much you are paying, then the type of service is also different. Pane charge ye condom, ne charge isiri condom. So nikuda mari kune vamwe vana vadiki vanopedzisira vaitwa taken advantage of. That is why they then get STIs and HIV at the end of the day. Yes, sir. I can say around reports, because it's not only me who see them, but my stakeholders, it's tower. One to tower, around 12 years. Then it has one of the pregnancy. Ministry of Health, former around the T5, do no record out Mazimai, I was a Sunungo Gandhi. Mugari analyze them, no Makari, to my 13, to my 14, she's 20. Either vakarekwa kana kuti vakatoita nhumbu yacho kunzi akarodzwa kana kuti akaita sex work. So ndo mama indicators at the moment. But of course, if you would also visit places like it's only that kwane COVID kudai kusina COVID mukana kunonzwa matenda iwo kuna chiwaridzo kwana glende kumaniraya. If you would tell you actually see them in action. Tunge tungoriko tunana sis because normally vanonga vaine ma big sisters. Because I know the sex inoita kune vanenge graduate vanenge vakuita ma-off-layer sort of vakuda trends. So they recruit new ones who they then use so that they get money. Saka kana vakechwa anenge achitanga kuzi kana tete kuti ndadi yakechwa then tete ndo anopuwa mari yacho uyo oenda neclient. Ndo some it's sort of brothel, I don't know which language is used, but ndo the way they come in. So kana vatojairira vana vaiveka vamwe vacho hanzi vanopinda kuchikoro vamwe vacho they actually go to school masikati vanenge vapfeka uniform manheru vanenge vakutrade. So it's this person I don't think is actually the problem yevana ndava inini from my own analysis ndakwanisa kuti iproblem yemaparents kana kuti maguardians avanogara now who then make use of them because they know that they're now marketable, but then exposing them to HIV. Was a competition, it seems like many would want the younger ones than what you could. It seems the ladies also know that. But they're also more expensive, but more risky as well.